Hello everyone, I am Dr. 𝗓𝐧𝐼𝐸𝐺𝐻. Today's topic is on anatomy of colon. So the large intestine is divided into four parts: cecum and appendix. And colon, which makes most of the large intestine, rectum, and anal canal. So here in this module, we shall be talking about the anatomy of colon, and for further descriptive purposes, the colon is divided into four parts: ascending colon, then transverse colon, transverse colon runs transversely, descending colon, and finally the sigmoid colon. The S kind of curve is called as sigmoid, so it is called sigmoid colon. Before discussing in detail regarding various parts of the colon, let's learn about the basic anatomy of large intestine. The large intestine extends from ileocecal junction. So here is the terminal part of ileum. So it extends from ileocecal junction. To the anus. So from ileocecal junction it extends till the anus. It begins as the cecum and vermiform appendix. So the dilated part is called as cecum, which is a blind pouch, and the thin worm-like structure is the vermiform appendix. So it begins as the cecum and vermiform appendix, which are usually located in the right iliac fossa. So here is the cecum, appendix, which are located in right iliac fossa. The colon makes up the longest part of large intestine. The ascending or the right colon passes upwards in the right flank to the right hypochondrium. So here is the right hypochondric region. So this is the ascending colon or right colon. So where in the right hypochondric region, it bends to the left to form hepatic flexure. So that is the right colic flexure, which is underneath the liver. So the ascending colon turns to form the transverse colon. So the turn is called as right colic flexure or hepatic flexure, and it turns to form transverse colon. So this loops across the abdomen with an anterior inferior convexity until it reaches the left hypochondrium. where it curves inferiorly to form splenic flexure or left colic flexure. From here, it descends into the left flank as a descending or left colon before continuing as the sigmoid colon in the left iliac region. And further it becomes rectum anterior to the third sacral vertebra. So we can see the sacrum here. So the rectum begins at the third sacral vertebra. The rectum transitions to the anal canal at the level of pelvic floor. In adult, the large intestine is approximately 1 to 1.5 meters long in vivo, but there is a considerable variation in individual. The mean internal diameter of the large intestine is 4.8 centimeters. The caliber of the colon is greatest near cecum. So, cecum is the widest part of large intestine. So, the longitudinal muscle layer forms 3 longitudinal bands instead of as uniform thickness all around the colon. So, here is the longitudinal muscle layer. So, the bands are called as 𝗠𝐞𝐝. Which are present on all parts of colon and cecum. The next distinguishing feature is the 𝐒𝐻𝐿𝐵𝐻 or seculations are the dilated parts in between the 𝗠𝐞𝐝 and they are responsible for characteristic puckered appearance of large intestine. So, these dilatations what we appreciate all in large intestine is 𝐻𝐿𝐵𝐻 or seculations, 𝐻𝐿𝐵𝐻 or seculations. The next important feature is the appendices 𝐒𝐵𝐵𝐞, which are the fat-filled bags of visceral peritoneum attached to 𝗠𝐞𝐝. So, this outpouching of fat diverticulae are appendices 𝐒𝐵𝐵𝐞. Ascending colon. The length of ascending colon is around 15 to 20 centimeters. It is retroperitoneal. It begins from cecum at the level of 𝐒𝐬𝐫𝐞 orifice and passes upwards from 𝗓𝐿 junction to the right to form hepatic flexure, where the ascending colon becomes transverse colon. So, this is ascending colon. This is vermiform appendix. And we can see the cecum, and here is the terminal part of ileum, and we can see the 𝗓𝐿 junction. So, from the 𝗓𝐿 junction till the hepatic flexure of colon is the ascending colon. Further it turns to form transverse colon. The ascending colon is retroperitoneal and it is connected to the posterior abdominal wall by Tolles fascia. So, the paracolic gutter, it lies between the ascending colon and lateral abdominal wall. So this is the lateral abdominal wall, and here is the paracolic gutter. Ascending colon has all three characteristics of large intestine, that is the tinea coli are anterior and posteromedial and posterolateral in position, which are the longitudinal muscle coat, and also sometimes the ascending colon possesses a mesentery called as ascending mesocolon. So retroperitoneum means behind the peritoneum, it is a retroperitoneal organ, we know ascending colon. So retroperitoneum is a potential space that exists between the peritoneal cavity and posterior abdominal wall, and structures that exist in this space include adrenal glands, so the glands above the kidneys, and kidneys, ureters, aorta, kidneys, ureters, aorta, and also it includes the inferior vena cava, duodenum, and duodenum is not seen in this image because the duodenum is removed to expose the kidney, and ascending and descending colon are also included as retroperitoneal organs. Relations of ascending colon: anterior to ascending colon there are coils of small intestine, you can see the coils of small intestine, and also the greater omentum, this yellow colored structure which is like an apron covering the abdominal organs is greater omentum. So let us discuss about the posterior relations of ascending colon. Posterior relations can be divided into two parts. Above the iliac crust, the transversus abdominis. So here in this image, the colon is removed and all the intestines are removed to expose the posterior abdominal wall and to explain the relations of posterior posterior relations of colon. So posteriorly we can divide the relations as above the iliac crust and below the iliac crust. So here is the iliac crust. So ascending colon is located towards right side, descending towards the left side. So above the iliac crust, ascending colon is related to transversus abdominis. Transversus abdominis, it is related to quadratus lumborum muscle. And it is also related to iliohypogastric ilioinguinal nerves. So posteriorly it is related to iliohypogastric and ilioinguinal nerves, which are not shown in this image. And it is the lower pole of the right kidney is also related. So we can see on the right side lower pole of right kidney. And below the iliac crust, the ascending colon is related to iliacus muscle. And it is related to lateral cutaneous nerve of thigh, and which are the posterior relations. So lateral cutaneous nerve of thigh is also not demonstrated here, which is a direct branches from lumbosacral plexus. So ascending colon is heavily involved in fluid and electrolyte reabsorption and gradually forming fecal matter. Hepatic flexure of colon. Hepatic flexure is formed by the junction between the ascending and the transverse colon. it overlies the anterior surface of the lower pole of right kidney. So here we can see the hepatic flexure of colon towards the right side just below the liver. And posteriorly, hepatic flexure of colon overlies the anterior surface of lower pole of right kidney. So here is the right kidney. And here is the right suprarenal gland. And this one is the hepatic flexure. And it is inferior surface of right lobe of liver is related above to the hepatic flexure. So, superiorly it is related to inferior surface of right lobe of liver. And it is also related to the second part of duodenum. We can see retroperitoneally part of duodenum here. And the second part of duodenum is present on the medial aspect, and fundus of the gallbladder, you can see the so the fundus of the gallbladder is present anteromedially. So here the fundus of the gallbladder is retracted to expose the hepatic flexure of colon. Posterior relations of hepatic flexure of colon. Here the hepatic flexure is removed to expose the posterior relations, and also the transverse colon is also removed to expose the posterior abdominal wall contents. So we can see only the ascending colon and descending colon on each side. So the posterior aspect of hepatic flexure is not covered by peritoneum, and it is in direct contact with renal fascia. So we can see the kidney here, which is covered by renal fascia, right kidney. And greater omentum often extends from its attachment to the transverse colon onto hepatic flexure. So we can see the greater omentum. Transverse colon. Transverse colon is the longest part of colon, which is around 20 inches to 50 centimeters in length, and it is the most mobile part of large intestine because it is intraperitoneal, means it is covered by peritoneum, and it extends from right colic flexure, which is present in right hypochondric region, to the left colic flexure, which is located in the left hypochondric region. So here is the transverse colon. So this is the right colic flexure, which is nothing but the hepatic flexure, and this is the left colic flexure, which is nothing but the splenic flexure of colon. At its right end, which is below the level of transpyloric plane, it is fixed. So the right end is the fixed part of transverse colon. And at its left end, above the transpyloric plane, in the left hypochondrium, it is fixed. So left end, above the transpyloric plane, it is fixed. The intervening part of transverse colon is suspended from the posterior abdominal wall by transverse mesocolon. So developmentally, the proximal 2/3, that is the right 2/3, means from here, right 2/3 and left 1/3. We can divide into proximal 2/3 and distal 1/3. So developmentally, proximal 2/3 is from mid gut and distal 1/3 is from hind gut. Arterial supply of the proximal 2/3 is by middle colic artery, which is a branch of superior mesenteric artery, artery of mid gut. Whereas the left 1/3, it is supplied by left colic artery, a branch of inferior mesenteric artery, which is an artery of hind gut. Nerve supply, proximal 2/3 it is supplied by vagus nerve and distal 1/3 by pelvic splanchnic nerves. Transverse mesocolon. Transverse mesocolon is attached from the lower pole of right kidney. So here the transverse colon is retracted to expose the transverse mesocolon. So the transverse mesocolon is attached from the lower pole of right kidney across the right second part of duodenum and pancreas to the upper pole of left kidney. So you can see the duodenum, pancreas. This is the lower pole of right kidney. And it extends up till the upper pole of left kidney. So here is the left kidney. So that is the extension of transverse mesocolon. The contents of transverse mesocolon are the transverse colon, middle colic vessels, you can see the middle colic vessels, ascending branches of left colic vessels, ascending branches of left colic vessels, and also the marginal artery, and it also contains the lymph nodes, lymphatics, nerve plexus embedded in the loose areolar tissue with variable amount of fat. External features: since the transverse colon is suspended by the mesentery, the position of 𝗠𝐞𝐽𝐻 coli is different. It is anterior, superior and posterior. So, let us see the posterior relations. So, the posterior surface of the right extremity is devoid of peritoneum, hence it is fused with the anterior part of duodenum. So, here is the duodenum. And transverse colon is removed here, and transverse mesocolon is also removed to expose the posterior relations in this image. The other posterior relations are the upper end of mesentery, duodenojejunal flexure and coils of jejunum and ileum. Anteriorly, the transverse colon is related to greater omentum. So, we can see the greater omentum with which it is fused. The greater omentum separates it from anterior abdominal wall. Superiorly, it is related to liver. So, we can see the liver here. The transverse colon is covered by greater omentum anteriorly, and it is related to gallbladder. It is related to greater curvature of stomach. And it is related to lateral end of spleen. And these are the relations, anterior relations of the transverse colon from right to left. Occasionally, the colon may be interposed between the liver and the diaphragm when it may be mistaken for free intraperitoneal gas on imaging. So, when associated with gastrointestinal symptoms, it is referred as 𝐒𝐫𝐢𝐻 syndrome. Left colic flexure or splenic flexure. So, here is a beautiful image demonstrating the splenic flexure. So, the left colic or splenic flexure is situated at the junction of transverse and descending parts of colon, and it is in relation with the lower end of the spleen and tail of pancreas. And the hilum of the spleen is related to tail of pancreas, which is also related to left colic flexure. So retroperitoneally it is present, it is a retroperitoneal part of colon. The splenic flexure lies at a higher level compared to hepatic flexure. So this side we can see the hepatic flexure at a lower level, and this is the splenic flexure at a higher level. It is attached to the diaphragm opposite to 10th and 11th ribs. So you can see the diaphragm. So it is attached to the left dome of diaphragm, and it in relation with to 10th and 11th ribs, opposite to 10th and 11th ribs, by a peritoneal fold named 𝗓𝐴𝐼𝐻𝐿𝐼𝐻 ligament. So the ligament between the splenic flexure of colon and diaphragm is called 𝗓𝐴𝐼𝐻𝐿𝐼𝐻 ligament, which assists in supporting the lower end of the spleen. Splenic flexure is the watershed region as it receives dual blood supply from the terminal branches of superior mesenteric artery and inferior mesenteric artery. So here is the superior mesenteric artery, this one is the inferior mesenteric artery. So we can see the branches of superior mesenteric artery and also the branches from the inferior mesenteric artery. So because of its dual arterial supply, it is considered as watershed region. So thus making it prone for ischemic damage. Thus making it prone for ischemic damage in case of low blood pressure, because it does not have its own primary source of blood. In the context of ischemia, the splenic flexure is sometimes referred to as Griffith point. It is called as Griffith point. So this Griffith's point which is along the upper rectum called as Sudak's point. Next, about the descending colon. The average length of the descending colon is 25 to 30 centimeters. And it extends from the splenic flexure. It descends from the splenic flexure in the left hypochondrium to the level of iliac crest. And where it curves medially anterior to the iliacus to become continuous with the sigmoid colon at the medial margin of left psoas major muscle. Descending colon is longer, narrower and more deeply placed than the ascending colon. Appendices epiploicae are more common in this part of the colon. In most of the individuals, it is retroperitoneal, covered anteriorly and both the sides by peritoneum. But occasionally the descending colon is more mobile, being suspended from the posterior abdominal wall by a short mesocolon. Its lateral peritoneal reflection is the left paracolic gutter. It is marked by a white line of Talt. So here is the paracolic gutter. Which is marked by white line of Talt. Let's see its relations. Anteriorly, the upper part is covered by terminal part of transverse colon and coils of intestine. So partially the descending, here is the descending colon which is covered by the transverse colon and also the coils of intestine we can see, and the lower part of the descending colon is in the left iliac fossa. So it is related anteriorly to the anterior abdominal wall When distended with gas or fecal matter, it can be palpated above the inguinal ligament. Posteriorly, the descending colon is related to upper part of anterior surface of lower lateral part of left kidney. So, here in this image, the colon and small intestine is removed to expose the posterior relations. And below the level of iliac crust, the posterior relations are iliacus. So, this is the left side, this is the right side. And it is also related to psoas major below the level of iliac crust. And it is related to lateral cutaneous nerve of thigh, femoral nerve and genitofemoral nerves. And external iliac artery, testicular vessels in males or ovarian vessels in females are also related posteriorly. The loaded descending colon may compress the left testicular vein, and this is one of the predisposing factor for the causation of varicocele, that is enlarged and dilated pampaniform plexus on left side. Next, regarding the sigmoid colon, sigmoid means S-like, so which is a curved part of colon is sigmoid colon. Sigmoid colon is about 15 inches, that is around 37.5 centimeters long, and connects the descending colon with rectum. The sigmoid colon runs from the lesser pelvis to the beginning of rectum at the level of third sacral vertebra. It is H-shaped and hence its name as sigmoid colon, and it is intraperitoneal, means it is covered by the peritoneum. The intraperitoneal parts of large intestine includes cecum, transverse colon and sigmoid colon, which are susceptible to volvulus. It usually lies within the pelvic cavity, anterior to rectum, on the peritoneal surface of urinary bladder and uterus in females. So, you can see the pelvic muscles. So, anterior to it, it is related to urinary bladder. So, anterior to rectum on the peritoneal surface of urinary bladder and uterus in females. So, tinea coli of the sigmoid colon are wider than elsewhere in the colon, and at its distal end to form a complete circumferential longitudinal muscle layer. So, the tinea coli at its distal end, it forms a complete circumferential longitudinal layer of large intestine, that is the sigmoid colon. Appendices epiploicae are particularly prominent in the sigmoid colon. Sigmoid or pelvic mesocolon. The sigmoid mesocolon is the fold of peritoneum that attaches the sigmoid colon to the pelvic wall. It is one of the four mesenteries in the abdominal cavity. The apex of V is attached to bifurcation point of internal and external branches of common iliac artery. So, at the bifurcation of common iliac, so here we can see faintly the common iliac artery. So, the apex of V is at the junction of bifurcation of common iliac artery, and it has two limbs. The lateral limb descends along the pelvic brim over the external iliac vessels and terminates at the level approximately to the midpoint of inguinal ligament. So, here this is the midpoint of inguinal ligament. So, the lateral limb descends down over the external iliac vessels. So, here is the external iliac artery and vein. So, that is the extension of lateral limb. whereas the medial limb descends into the pelvis and ends in the midline anterior to the third sacral segment. So, medially it extends till the third sacral segment where it continues to form the rectum at that point. Sigmoid and the superior rectal vessels run between the layers of sigmoid mesocolon, and the left ureter descends into the pelvis between its apex. Histology of colon. Histology of colon shares similar features as the digestive tube, where it contains mucosa, submucosa and muscularis along with serosa and adventitia. So, the mucosa is lined by simple columnar epithelium. So, from here to here is the mucosal layer. So, it is lined by simple columnar epithelium. That is lamina epithelialis with a long microvilli, and it is covered by a layer of mucus which aids the transport of feces. Lamina propria contains mucosa associated lymphoid tissue that is called as malt. So, lamina propria is the connective tissue just below the epithelial layer. Which contains malt, mucosa associated lymphatic tissue, and it contains blood vessels. So, the mucosa does not contain villi but many crepes which are called as crepes of 𝐒𝐫𝐞. So, we can see lot of crepes. These depressions are called as crepes of 𝐒𝐫𝐞. With numerous goblet cells interspersed along with the columnar cells. So, the empty cells, pot-like cells are all goblet cells. And along with the goblet cells, enteroendocrine cells are also found, which are similar to columnar cells. Next, the connective tissue, that is the lamina propria. So, lamina propria mucosae is filled with macrophages, plasma cells and other immune cells. Submucosa. Submucosa comprises blood vessels, Meissner's plexus and the lymph nodes, particularly the fat tissue. And one thing to say here, between the mucosa and submucosa, they are separated by a thin layer of muscle which is called as muscularis mucosa. Muscularis mucosa contains inner circular and outer longitudinal layer of muscle, which is a thin layer of smooth muscles, and this muscularis mucosa is a part of mucosa itself. Submucosa comprises blood vessels, so we can see several blood vessels, lymphatics, and also it contains Meissner's plexus, Meissner's nerve plexus, and it contains lymph nodes and particularly fat tissue. Next, muscularis propria. The muscularis propria is the muscle layer which contains inner circular musculature of the muscularis is strongly pronounced, whereas the outer longitudinal musculature is particularly found in 𝗓𝐻 coli. So, inner circular and outer longitudinal layer. And the nerve plexus which are located between inner circular and outer longitudinal are Auerbach's plexus or mesenteric plexus. And next about the serosal layer. Serosal is the outermost layer. Serosa is formed by the mesothelium of visceral peritoneum. So the part of colon which is covered by the peritoneum, the outermost layer is the serosa. And non-peritoneal layers, the outermost layer is a layer of connective tissue which is called as adventitia. So if we look at the development of colon, the midgut gives rise to ascending colon and proximal 2/3 of transverse colon. So ascending colon and proximal 2/3 of transverse colon is derived from the midgut, and the derivatives of midgut are supplied by superior mesenteric artery. So superior mesenteric artery is the artery of midgut which divides the midgut into pre-arterial and post-arterial segment. So colon is basically from the post-arterial segment. So that is ascending colon and proximal parts of 2/3 of the transverse colon is from the post-arterial segment of midgut. So the derivatives of midgut are supplied by superior mesenteric artery. So till here it is supplied by superior mesenteric artery. Other derivatives of midgut: distal half of duodenum, jejunum, ileum, cecum and appendix. The hindgut gives rise to distal third of transverse colon. So distal 1/3 of transverse colon, and it gives rise to descending colon, and also it gives rise to sigmoid colon, rectum and upper 2/3 of anal canal. So sigmoid colon, rectum and upper 2/3 of anal canal. So the derivatives of hindgut are supplied by inferior mesenteric artery. So it is the direct branch from the abdominal aorta is. In this image, superior mesenteric artery alone is shown. So inferior mesenteric artery is the artery of hindgut. The arterial supply, the colon is supplied by middle colic artery, right colic artery, ileocolic artery, left colic artery, sigmoidal arteries and superior rectal artery. So the middle colic, right colic and ileocolic arteries, they are the branches of superior mesenteric arteries. And the last branches, that is left colic and sigmoidal arteries and also the superior rectal arteries, they are the branches of inferior mesenteric artery. So superior mesenteric artery gives off inferior pancreatico-duodenal artery posteriorly and middle colic artery, right colic artery and ileocolic arteries from the right side, and the several anastomosing jejuno-ileal branches from the left side. So middle colic artery. Middle colic artery splits into right and left branch at the intestinal boundary of transverse mesocolon. So here we know the superior mesenteric and inferior mesenteric artery, which are direct branches of abdominal aorta. So starting with the middle colic artery, which is a branch of superior mesenteric. So middle colic artery splits into right and left branch at the intestinal boundary of transverse mesocolon. The right and left branches of middle colic artery forms anastomoses with the ascending branch of right colic artery and ascending branch of left colic artery respectively. So here is the left colic artery. The right colic artery. So the middle colic artery goes on to supply the colon from the right colic, that is hepatic flexure, along the transverse colon and almost the left colic splenic flexure. The right colic artery runs horizontally to the right side and divides into ascending and descending branches. The descending branch of right colic artery anastomoses with the superior branch of iliocolic artery. The right colic artery supplies ascending colon above the cecum to the right colic flexure. Next, about the ileocolic artery. Ileocolic artery also arises from the right side of superior mesenteric artery and travels towards the right iliac fossa. It gives a superior, that is the colic, and the inferior, that is the ileal branches. So, it gives off colic branches and ileal branches. Colic branches are superior and ileal branches are inferior. So, the inferior ileocolic branch travels to the ileocolic junction, where it gives off an anterior and posterior cecal arteries and an appendicular artery before continuing to the left and anastomosing with the terminal segment of superior mesenteric artery. Each branch of ileal artery, that is ileal branch of ileocolic artery, supplies anatomical section from which it is named. So, rest of the colon from the distal transverse colon to the recto-sigmoid junction is supplied by inferior mesenteric artery. So, as mentioned earlier, the left colic artery, sigmoid arteries and superior rectal arteries are all branches of inferior mesenteric artery. Left colic artery. The left colic artery is the first branch of inferior mesenteric artery and supplies marginal artery and supplies to form a marginal artery, and it ascends retroperitoneally to the left, dividing into two branches, ascending and descending branches. Ascending branch passes anteriorly to the left kidney, then enters the transverse mesocolon and passes superiorly to supply the upper part of descending colon and to the distal part of transverse colon, and anastomoses with the branches of middle colic artery. Descending branch passes inferiorly and supplying the lower part of the descending colon, anastomoses with the first sigmoid artery. And regarding the sigmoidal arteries are the series of about 4 loops of vessels resting on the in the sigmoid mesocolon that anastomose with each other. So, the last of which anastomoses with the superior rectal artery. Finally, the vessels that course parallel to the colon are often referred to marginal arteries. These marginal arteries gives off arteria recti, that is the straight arteries which supply the colon directly. Superior rectal artery. It is the terminal branch of inferior mesenteric artery. Superior rectal artery supplies the rectum downward to the level of levator ani. It gives off recto-sigmoid branch, upper rectal branch and right and left terminal branches. It anastomoses with the middle rectal artery, which is a branch of internal iliac artery, and inferior rectal artery, branch of internal pudendal artery. Then a marginal artery of Drummond. The marginal artery of Drummond, also known as the marginal arcade, is an anastomotic arterial channel that supplies the large intestine. It extends from ileocecal junction to the recto-sigmoid junction. As it runs in the close proximity along the inner border of the large intestine, it is sometimes referred to as juxtacolic artery. The marginal artery of Drummond is formed by the anastomosing terminal branches of superior mesenteric artery. So, the terminal branches of superior mesenteric artery are ileocolic, right colic, middle colic arteries, and also it anastomoses with inferior mesenteric artery, branches of inferior mesenteric artery. The branches are left colic and sigmoid arteries. The most direct communication between the superior and inferior mesenteric arteries is established in the arcade of Riolan. Arcade of Riolan which is a portion of marginal artery of Drummond formed between the right side of transverse colon and the upper descending colon. So this connection clinically it is quite significant, which provides the collateral blood flow in the event of stenosis or occlusion. Marginal artery of Drummond gives off numerous small branches called as straight arteries or vasa recta that supply blood to the large intestine. The junction of superior mesenteric artery and inferior mesenteric arteries, territories like splenic flexure, that is the where it receives a dual supply from superior mesenteric branches and inferior mesenteric branches. So anastomoses here are often weak or absent. So hence the marginal artery at this point is known as Griffith's point. So at this point it is known as Griffith's point and is often focally small or discontinuous. For this reason, the splenic flexure is the watershed or the border zone area which is prone to ischemia and infarction. Venous drainage of colon, the veins draining the colon accompanying the arteries. The veins accompanying the 𝐒𝐫𝐽𝐸𝐽, right 𝐾olic and middle 𝐾olic arteries all join to form the superior mesenteric vein. So 𝐒𝐫𝐽𝐸𝐽, right 𝐾olic and middle 𝐾olic. All are draining into superior mesenteric vein. While the veins accompanying the branches of inferior mesenteric artery joins to form inferior mesenteric vein, that is superior and inferior mesenteric veins finally drains into portal circulation. So here is the inferior mesenteric vein. Superior mesenteric vein joins with the splenic vein. And we can see the inferior mesenteric vein draining into splenic vein. So superior mesenteric and splenic vein joins to form portal vein. So finally the venous drainage is into portal vein. Lymphatic drainage. The lymphatic drainage of colon is important since the carcinoma of colon spreads by lymphatic route. So there are numerous lymphatic colic lymph nodes collecting the lymph from the colon. So the colic lymph nodes are arranged in 4 groups. That is, so the minute epiploic nodes are located on the wall of the colon, and paracolic nodes lie very close to the marginal arterial anastomoses, and intermediate colic nodes lie along the right, middle and the left colic arteries, and the pre-terminal nodes lie along the trunks of superior and inferior mesenteric arteries. So finally the pre-terminal nodes are along the superior and inferior mesenteric arteries. Nerve supply. Superior and inferior mesenteric nerve plexus supply the colon. So here the superior mesenteric nerve. Inferior mesenteric nerve plexus. So parasympathetic supply. The vagus supplies the part of colon that develops from midgut, that is ascending colon and right 2/3 of the transverse colon, that is the part where the vagus nerve supplies. So till here the vagus nerve. That is the 10th cranial nerve. Pelvic splanchnic nerves, which are otherwise called nervi erigantis, derived from S2, S3, S4, gives rise to nervi erigantis, supplies the colon that are developed from hindgut. So these are from hindgut until proximal 2/3 of the transverse colon is from midgut. afferent nerve supply, that is the visceral pain sensation from the ascending colon and transverse colon travels through lesser splanchnic nerves to T10 and T11 segments of spinal cord. Hence, pain is referred to the umbilical and hypogastric region. Pain from the descending and the sigmoid colon is carried by lumbar splanchnic nerves to L1 and L2. Segments of spinal cord, hence pain from these parts are referred to inguinal region and thigh.